Please go ahead.
Okay,
Excuse me. Hello.
Yes.
What about the recording? I hope we've paused the previous recording and started again.
Yeah, I just did.
Thank you, sir. Thank you.
Okay, as a way of introduction, as you all know, pulmonary embolism is a type of, is a kind of venous thromboembolism, which is a condition that's characterized by abnormal blood clot formation in the pulmonary arteries and the vein vasculature. It is globally the third most frequent acute cardiovascular syndrome behind myocardial infarction and stroke, and it contributes to substantial cardiovascular morbidity and mortality. So, as I said earlier, it comprises of two interrelated conditions that are part of the same spectrum. You have the deep vein thrombosis and the pulmonary embolism, which is where we're going to base our discussion this evening. Pulmonary embolism is a manifestation of venous thromboembolism that involves the occlusion of the pulmonary vasculature by any material from a distant site. This may be a thrombus, amniotic fluid, septic emboli, fat, air, and other gases. In majority of cases, it's actually caused by blood clots that travels from the leg or pelvis, and rarely the upper extremities. 50% of patients with DVT may have evidence of clinical or subclinical pulmonary embolism. And because of its non-specific presentations, it may be described as the great masquerader, which actually in most cases, you need a high index of suspicion actually to make the diagnosis. The annual incidence of pulmonary embolism is estimated at 60 to 70 cases per 100,000 population, with a rising incidence tendency over time. In the United States and Europe, it accounts for 100,000 and 20,000 annual deaths respectively. And most deaths from these conditions are mostly sudden, mostly from caused by pulseless electrical activity. Now, among adults greater than 65 years in the United States, the in-hospital case mortality is about 4%, with a 30-day readmission at 15%. And 6 months mortality rate is up to 20%. But the good news is that in recent years, the case fatality rate has been decreasing, or anyway, depending on where these cases are seen. And this may be as a result of more effective therapies and interventions, possible better adherence to guidelines, and also in some cases maybe because of overdiagnosis of PE, because if most time patient presents and probably it's not PE, and you end up managing as PE, so you may record it as a case of pulmonary embolism, thereby increasing making it look like it's decreasing. Then the incidence is said to increase with age, 8 times higher in individuals greater than 80 years than those in the 5th decade of life. In terms of gender, there have not been well-documented evidence that there's any difference. These are actually the risk factors of that may predispose an individual to development of this condition. Have the family history of thrombus cancer, up to smoking, and even hereditary symptoms, conditions like factor V guidance, protein C, or X deficiency. This can actually be grouped into the strong risk factors, moderate risk factors, and also the weak risk factors as listed. Now, looking at the pathophysiology of pulmonary embolisms, the pathogenesis of pulmonary embolism, as you all know, is driven by virtuous triads of venous stasis, endothelial injury, and the hypercoagulable states, which often activate the pathophysiological cascade that leads to VT. I would like to look at the pathophysiology of these conditions using looking at the hemodynamic changes, what happens in terms of gas exchange and hypoxemia. Basically, what happens in this condition that it both affects the circulation and the gas exchange. Now, in terms of hemodynamics, when there is more than 30% of total cross-sectional area of pulmonary artery that's included by any of these materials like microemboli, this results to increase in pulmonary arterial pressure, which of course may lead to vasoconstrictions, which is mediated by the release of thrombosins to A2 and serotonin. And this contributes to the initial increase in the pulmonary vascular resistance. Now, the anatomical obstruction that occurs and the vasoconstriction in the affected lung area would lead to an increase in pulmonary vascular resistance and a proportional decrease in arterial compliance. With abrupt increase in peripheral vascular resistance, there will be a right ventricular dilatation, which alters the contractile properties of the right ventricle through the fractional mechanisms. Okay, now following the increase in the right ventricular pressure and volume, of course, will lead to increase in wall tension and myocyte stretch, which will now lead to release of some biomarkers. Then the contraction time of the right ventricle will also be prolonged. And following the release or activation of the renal hormones, there will be iotropic and chronotropic stimulations. Now, together with the vasoconstrictions, these compensatory mechanisms will increase the pulmonary arterial pressure, thereby improving, in an attempt to improve the flow through the obstructed pulmonary vascular bed, and in order to temporarily stabilize the systemic blood pressure. But however, the extent of immediate adaptation is limited in this case, as a non-preconditioned thin wall, because the right ventricle has a thin wall, will be unable to generate a mean arterial pressure that's greater than 40 Newton of mercury. Now, prolongation of the right ventricular contraction time into the early diastole in the left ventricle will lead to left bowing of the interventricular septum, and then the interventricular septum will flatten up during systole, and then bulges towards the left ventricle with a paradoxical septal washout motion. This actually leads to what we call the D-septum that we see on echo. Now, as a result, the left ventricular filling will be impeded in early diastole, and this may lead to reduction in cardiac output, and of course, to contribute to hypotension and hemodynamic instability. Now, because of excessive neurohormonal activation in pulmonary embolism, this may result to both abnormal ventricular wall tension and circulatory shock. Then association between the elevated circulatory level of biomarkers of myocardial injury and the adverse early outcome actually indicates that right ventricular ischemia is of pathophysiological significance in the case of pulmonary embolism. Now, the right ventricular infarction is said to be uncommon after PE, but the imbalance between oxygen supply and demand can result in damage to cardiomyocytes, and of course further reduce the contractile forces. The acute right ventricular failure due to acute pressure overload is said to be the critical determinant of clinical severity and outcome in acute pulmonary embolism. This actually just a representation of what happens in terms of the hemodynamics because of the increased ventricular volume overload. May lead to right ventricular wall tension, which of course will result to reduction, increase in right ventricular oxygen demand, the right ventricular ischemia. Of course, all this lead to affect the left ventricular preload because of the decrease in the right ventricular output, which goes on to cause decrease in the coronary perfusion of the right ventricle. Now, looking at the gas exchange, as you all know, in normal lungs, the ventilation and perfusion are well matched, and the ratio of ventilation to the gas exchange structures and blood flow to the pulmonary capillaries are approximately 1. So transfer of oxygen is impaired when alveolar ventilation of pulmonary alveolar ventilation to pulmonary capillaries is reduced relative to blood flow. So the ratio in this case will fall less than 1. Now, in acute PE, there's impairment of this efficient transfer of oxygen and carbon dioxide across the lungs. Now, decreased arterial oxygen and an increase in the alveolar arterial oxygen tension gradient is the most common gas exchange abnormalities that you see in pulmonary embolism. And of course, there will be a total increase in the death space, and then ventilation and perfusion becomes mismatched with blood flow from obstructed pulmonary arteries redirected to other gas exchange units. This may lead to shorting of blood, venous blood into the systemic circulation, which may occur, but there is no ventilation when there is no ventilation to the perfused lung unit. Now, in terms of hypoxemia, several mechanisms explain the presence of arterial hypoxemia in the setting of acute PE. Now, unlike in normal lungs where the ventilation is well matched to blood flow, pulmonary embolism causes redistribution of blood flow so that some lung gas exchange units have low ratio of ventilation to perfusion, where others may have excessive high ratios. Now, mismatching of ventilation and perfusion is the most common cause of impaired pulmonary oxygen transfer. Now, arterial hypoxemia occurs when venous blood flows through lung gas exchange units, where the ratio of ventilation to capillary blood flow is reduced. Now, another mechanism that may also cause reduced ratio of ventilation to perfusion is atelectasis, which of course may be as a result of maybe loss of surfactants and even hemorrhages in the pulmonary parenchyma. Now, in about 1/3 of patients, right to left shunting through a patent foramen ovale can be detected by echocardiography. And this is actually caused by an inverted pressure gradient between the right atrium and left atrium, and may lead to severe hypoxemia and increased risk of paradoxical embolization and stroke recorded. Now, looking at the clinical presentation, like I said earlier, the presentation is mostly non-specific, but it may vary from sudden onset to gradual progressive dyspnea. And he said that dyspnea may be acute and severe in case of central PE, but in small peripheral PE, it's often mild and may be transient. Now, in patients with pre-existing heart failure or pulmonary disease, worsening dyspnea may be the only symptoms that may be indicative of pulmonary embolism. So it actually requires a high index of suspicions, like I said earlier. And chest pain, which is a frequent symptom, usually caused by pre-irritation due to distal emboli, may actually also be present. Now, patient may actually present in form of hemodynamic instability, which is actually an important form of clinical presentation and indicates central or extensive pulmonary embolism with severe reduced hemodynamic reserve. On the right side is just what defines hemodynamic instability, which can actually be in form of cardiac arrest, where there is need for cardiopulmonary resuscitation, or it may be in form of obstructive shock, where there is requirement for vasopressors to achieve a blood pressure that's greater than systolic blood pressure greater than 90, or where there is an end organ hypoperfusion. It also can be defined as a persistent hypotension less than 90 meters of mercury, or when there is a systolic blood pressure drop more than equals to 40 meters of mercury, and which may last longer than 15 minutes and not caused by new onset arrhythmia or hypovolemia. Now, another typical form of pulmonary embolism can also be a syncope, which can be seen in about 70% of cases and associated with high prevalence of hemodynamic instability. Now, these are other presentation how these patients may present: tachypnea, rales, tachycardia, or even up to cyanosis. It's important for us to know that in some cases, pulmonary embolism may be asymptomatic, or it may be discovered accidentally during a diagnostic workup for other diseases. Now, looking at the diagnosis, um, it actually, like I said, it requires a high index suspicion. So, awareness of the risk factors and the clinical suspicion for PE are paramount important. And the most important approach is a clinical assessment of likelihood, which is based on presenting symptoms and signs, and the use of laboratory testing with diagnostic imaging. Now, there are several scores that has actually been developed to assist in the clinical assessment of likelihood of this patient. Have the revised Geneva rules, and of course the Wells score. These are the revised Geneva scores. Here we have the original version and the revised version. We're looking at the some clinical parameters, there's a history of previous PE, heart rate, hemoptysis. I think we all know this. And then looking at this, looking at the clinical probability at the 3-level score, if usually the reverse version, if you have about 0 to 1, then that's low. And then intermediate is 2 to 4. Then if it's more than the score is more than 5, then that can be regarded as being high probability. Then you can also have a 2-level score where you have the PE unlikely and the PE likely. Now, the Wells score is actually developed also in the assessment of this patient, whereby you want to look at the clinical signs of DVT, heart rate greater than 100 beats per minute. In case of recent surgery or amputation, hemoptysis, and malignancy. So you can say PE is unlikely if using the original Wells score, if it's less than or equals to 4, and if it's more than 4, then it may be regarded as being likely. Then the clinical probability, it's important for us to know that regardless of the score that is used, the proportion of confirmed PE can be expected as follows: 10% in low probability, 30% in medium probability. In high probability, we also be as high as 65%. Now, when 2-level classification is used, we want to look at the PE unlikely, which is found in about 12%, and then 30% in PE likely. Now, looking at in order to avoid overdiagnosis or overuse of this diagnostic test, so you have what we call the pulmonary embolism rule-out criteria, which is actually developed with the purpose of selecting patient on clinical grounds, most likely hold of having PE is low, so that to carry out any diagnostic investigations, because some of those investigations can actually be expensive. So this actually comprises of 8 clinical variables that are associated with absence of PE. So if you have any of these, or maybe while you're assessing your patient and the patient does not fall in any of these, then it may actually can actually help to rule out PE. Now, this actually shows, or just to tell us about the clinical evaluation, which is recommended, is a class 1 indication that is recommended. Sorry, it's a little bit broad. It's recommended that the diagnostic strategy be based on clinical probability, which is assessed either by clinical judgment or by validated prediction rules, as I said before. Now, looking at the non-imaging diagnostic methods, now the D-dimers, which is actually the evidence of intravascular thrombosis, okay, and then it has a high negative predictive value for PE, but it never used to confirm PE. Then it's important for us to know that it can be elevated in cancer, pregnancy, inflammatory bowel disease, or even in active MI. And also and others. Now, a negative D dimer with a low probability clinical testing will exclude a pulmonary embolism with accuracy. But it's important to know that in case where there is a high clinical probability for PE, then with concomitant negative D-dimer, that does not exclude pulmonary embolism. So now it is an ELISA. Also, the ELISA-derived assay is actually the one that is mostly used, which diagnoses sensitivity of more than 95%, and it excludes PE in patients with either low or intermediate pretest probability. Now, you also have what we call the age-adjusted D-dimers, which is also very important, especially in the elderly people, where it tends to, as patient always tends to increase. So most time you may not want to depend more on what you get as regards to the value. In most cases, you have to multiply the patient's age by 10 in order to get a value that you may need. Now you also have what we call the D-dimer cutoff adapted to clinical probability. So what try to tell us that it's important to relate whatever that we get in terms of lead dimers into a clinical probability, so that you have to help you make a diagnosis, help you make tell you whether the patient is more likely to have a pulmonary embolism or not. They have point of care lead dimer access, which is most useful in the rural areas or where patients are not able to access care, maybe toward those established diagnostic images. So it actually help you to quickly rule out whether this patient has probably a possibility of having pulmonary embolism or not. Now, the use of D-dimer is actually a class 1 indication that where plasma D-dimer measurement, preferably using a highly sensitive assay, is recommended in outpatients or emergency department patients with low or intermediate clinical probability, or those that are PE unlikely. You have to reduce the need for necessary imaging and irradiation. It could also be class 2A, where as an alternative to the fixed D-dimer cutoff. So a negative D-dimer test using age-adjusted cutoff, that's age times 10 microgram per liter, in patients that are greater than 50 years should be considered for excluding PE in patients with low or intermediate clinical probability, or those that are PE unlikely. Now, the electrocardiogram is one of the investigations that can also be useful in evaluating this patient, and it helps to exclude other conditions that may mimic pulmonary embolism, such like acute pericarditis or myocardial infarction. As we all know, changes that are indicative of a right ventricular strain, the infection of T wave in V1 to V4, or whereby you have the S1 Q3 pattern, a Q3 T3 pattern, and in most cases we also have a complete right-bundle branch block. Now, in minor cases, the only abnormality may be sinus tachycardia, which is actually present in about 40% of patients. Now, it's important to know that even in some cases, the ECG may even be normal. Okay, it's not very specific in terms of assessing this patient. But when you see some of these features, so to actually be indicating that there is something happening on the right side. Now, this is just the mechanism of disease changes in pulmonary embolism. Of course, the sanitary academy be as a result of increased adrenergic drive, which of course occurs when this patient goes into some form of hemodynamic compromise. Then it can also be due to right atrial or right ventricular dilatation, which may cause a complete right bundle branch block, right atrial deviation, or even dominant R wave in V1. Then, if this progresses, then they have some right ventricular strain where you have the S1 Q3 T3 pattern that is very seen in this patient. Now, this ECG just shows the inferior link, that's the 2, or the 3. But you can see the Q in S in the Q wave, and the T wave inversion in the 3, and of course the S wave in in 1. Of course, the T wave inversion from the V1 to V4 is also shown here. I don't know. Okay, sorry. Okay, now look at the imaging diagnostic method. We want to look at the chest features of pulmonary embolisms. Most times these are usually subtle, and just like ECG, sometimes it may even be not, and so it's not very diagnostic. So, but this just to show some of the signs that are seen in pulmonary embolisms, that may be seen in pulmonary embolisms. I think each of these actually have an arrow that is pointing to it. They may have what we call the Westermann sign, the Houghton signs, the knuckle signs, the Feller signs. Okay, and then also a pulmonary effusion may be seen in patients with pulmonary embolisms in about 50% of cases, but are small and they involve only just blunting of the costophrenic angle. Now, the echocardiography is used for a patient with suspected massive PE who are too ill for transportation. So the combination of pulmonary injection acceleration time less than 60, that's with a peak systolic diastolic valve gradient less than 60, that's the one called the 60 sign, or with a depressed contractility of the right ventricular free wall compelled to the apex, that is the McConnell sign, is suggestive. It's suggestive of pulmonary embolism. Now, detection of echocardiographic signs of right ventricular pressure overload may help to distinguish acute PE from right ventricular free wall hyperkinetic, okay, which actually may be the McConnell's sign. Now, however, they probably have low sensitivity. Okay, that's the echo. Have low. Some of these signs have low sensitivity as a standalone finding. So it's important to also look at the other clinical variables that may have to help you to tie down or diagnose this patient as PE. Now, transesophageal echo is also useful in most cases where there are some conflicting results in order to clarify the result based on endocarditis or pericarditis. Now, these are actually some of these features that are seen in echocardiography in case of acute pulmonary embolism. Now you have the enlarged right ventricular external short axis view. Okay, we have the dilatation. You can see quite dilated. Okay, on the long axis view. Then looking at the apical view, you can see it's also dilated. Then you have you have the G sign that is also seen because of the increase in the right ventricular pressure overload and the volume load. Okay. Okay. Now the here also you have the D, you have the distended field vena cava, okay, which is actually diminished on its respiratory coagulability. Okay. Okay. Now you have the 60-60 signs, and also have on the F you have the right heart mobile thrombus. You can actually see a thrombus on transit. Okay, on the echo. Okay, so now you also have the decreased pitch systolic velocity can also be seen. Okay, now the echocardiographic examination is not mandatory as part of the routine diagnostic workup in hemodynamically stable patients with suspected PE. Okay. Now, in suspected suspected high risk pulmonary embolism, absence of echocardiographic signs of right ventricular overload or dysfunction practically exclude pulmonary embolism as the cause of hemodynamic instability. Now, what echo does, it may actually help to initial diagnosis of the cause of shock, whereby you may detect a pericardial tamponade, acute valvular dysfunction, or even severe global or regional electrical dysfunction, okay, or aortic dissection. Now, you can also use the compression ultrasonography, okay, which in majority of cases, where because a PE most time may actually originate from the DVT in the lower limbs, and this and also rarely in the upper limb. So, compression ultrasonography has a sensitivity of more than 90%, that's basically of 95% for proximal symptomatic DVT. Okay. Now, a positive proximal CUS results has a high positive predictive value for PE. Now, incomplete, this actually shows that incomplete compressibility of the event, which may indicate the presence of a clot in the only validated, which indicates the presence of clot. So this is the only validated diagnostic criteria, at least to for DVT. Okay. Now, this actually just shows the use of this compression ultrasonography as a class 1 indication. So it is recommended to accept the diagnosis of VTE or pulmonary embolism if the CUS shows a proximal DVT in a patient with clinical suspicion of pulmonary embolism. Now, as class 2A, if it shows only a distal DVT, so further testing should be considered to confirm PE. But if positive proximal CUS is used to confirm PE, then assessment of PE severity should be considered in order to permit risk adjustment management. So this is also a class 2A indication. Now, using the ventilation perfusion scanning, now this is only you have the ventilation phase and the perfusion phase. Now, performing only a perfusion scan might be acceptable in patients with normal chest X-ray, and any perfusion defect in this situation would be considered a mismatch. So we may have a three-tier classification where you have the normal scan that excludes PE, and then high probability scan considered diagnostic of PE, and then you may have a non-diagnostic scan. So it is recommended to reject diagnosis of PE without further testing if the perfusion lung scan is normal. It's actually a class 1 indication as shown here. Okay. Now, the CT pulmonary angio is actually the gold standard. Okay. Now, in prospective investigation on pulmonary embolism diagnosis, okay, it's observed that the sensitivity of 83% and the specificity of 96% for CTPA will actually be used in assessing this patient. Now, in patient with a low or intermediate probability of PE, now a negative CTPA have a high negative predictive value for PE, but this negative predictive value was only 60% if the predictive probability was high. Now, conversely, the positive predictive value of a positive CTPA was high. That's at about 92 to 96% in patients with an intermediate or high clinical probability, but much lower in patients with a low pretest likelihood of PE. Now, it is recommended, the class 1 indication, it is recommended to reject the diagnosis of PE without further testing if CTPA is normal in a patient with low or intermediate clinical probability or who is PE unlikely. Now, it's also recommended to accept diagnosis of PE without further testing if CTPA shows a segmental or more proximal filling defect in a patient with intermediate or high clinical probability. As a class 2A indication, it should be considered to reject diagnosis of PE if CTPA is normal in patients with high clinical probability or who is PE unlikely. Okay. Okay. Now, assessment of severity and risk of death. Now, initial risk stratification is based on clinical symptoms and signs of hemodynamic instability. Now, advanced risk stratification requires the assessment of two prognostic criteria. You have the clinical, imaging, and laboratory indicators of embolism severity, which is mostly related to the presence of right ventricular dysfunction. So, you actually need echo. Okay. Now, you also have the presence of comorbidity and any other aggravating condition that may adversely affect any prognosis. So this is actually the advanced risk classification and what you actually need to look at the prognosis criteria. Now, using echo in this case, if there is a right ventricle RV stroke LV diameter ratio greater than 10, greater than 1, and a TAPC less than 17 or 16, depending on the guideline that you're using, it may be unfavorable. Okay. Then right to left shunt through a PFO and the presence of right heart thrombi, which actually increase mortality risk in P. So when you find all this in an echo, will actually help in assessing the prognosis in this patient. They're using the CTPA, meta-analysis of 49 studies investigating about 13,000 patients will be confirmed that an increased RV LV ratio greater than 1 on CT was associated with a 2.5-fold increased risk for all-cause mortality and with a 5-fold risk for PE-related mortality. Now, apart from right ventricular size and the RV LV ratio, CT may provide further prognostic information, okay, based on volumetric analysis of the heart chambers and assessment of contrast reflux.
Hello, Dr. Ibe. Hello. Massive lost him. Am I audible to the rest of the?
Yes, you are.
Yes.
Okay. Let's be patient a bit and give him a few minutes to get back online. Florence, please, can you reach out to him to just find out if he can get back online soon?
All right. Okay.
I'm here, sorry. I had my name.
Sorry, it was Dr. Briggs, Florence Briggs.
Okay.
He's trying to log in.
Okay, that's fine. Thank you. We'll just give him a few minutes.
Hello?
Yes, Dr. Ibe, we can hear you. Please share your screen.
Yeah, sorry, I didn't even know that my.
Okay, so you can go on slideshow.
Hello? Where did I stop, please? I don't know where.
Yeah, I think you can continue from here.
Okay. Please, just give me a minute. Just a minute, please. Let me on the light.
Yeah, you can go ahead, please.
Okay, thank you. Okay. So sorry for that. Interruption. Now, looking at the imaging of the right ventricular size of the function. Now, using the echo, we want to in the assessing the prognosis factor of this patient. We want to look at the right ventricular stroke, the LV diameter ratio. If it's greater than 1, the tap speed is less than 70. Now, right to left shunt, if there's a right to left shunt through patent pulmonary and the presence of right heart thrombi, this is actually a indication of increased risk, mortality risk in patients with pulmonary embolism. Sorry, my slides are not moving.
Yeah, click on the slide and then you attempt to move it. You move. Click on the slide.
Okay, it's moving now, right? Okay, sorry. Hello, Dr. Kante, is it moving, right?
Yeah, it's moving now. It's moving.
Okay, now using the CTPA, like I said earlier, the meta-analysis of meta-analysis of 49 studies investigating more than 13,000 patients with PE confirmed that an increased RV-LV ratio greater than 1 or CT was associated with a 2.5-fold increased risk for all-cause mortality, okay, and with a 5-fold risk for PE-related mortality. Now, apart from RV size and RV-LV ratio, CT may provide further prognostic information based on volumetric analysis of the right of the heart chambers and also assessment of contrast reflex to the IVC. Now, using the laboratory biomarkers. Now, markers of myocardial injury is very useful here, where if there is an elevated plasma troponin concentration on admission, may actually be indicative of worse prognosis in acute phase. Now, this can actually we can actually use the conventional or the high sensitivity assay of troponins. Now, you also have what they call the heart type fatty acid binding proteins, okay, which is an early and sensitivity marker for myocardial injury, and it actually provides prognostic information in terms of acute PE. Then markers of right ventricular dysfunctions. if there's a stretch of this may release a BNP and NT-proBNP. So elevated levels such as NT-proBNP more than 600 milligrams per liter may provide additional prognostic information. Now, other laboratory markers are the lactate, now, which is actually a marker of imbalance between tissue oxygen supply and demand. Now, it may reflect severe PE with overt or imminent hemodynamic compromise. Now, plasma level that is greater than or equals to 2 millimole per liter may predict PE-related complications. Now, you can also use the serum creatinine levels with a decreased EGFR. So it's actually related to a 30-day all-cause mortality when there is a reduction in the EGFR. Now, vasopressin, which is actually released upon endogenous stress, hypotension, and low cardiac output, is a surrogate marker. Okay, it has with the surrogate marker, which is the co-13, has been reported to be useful for risk stratification of patients with PE. Now, scores for assessment of pulmonary embolism severity. You know how this is the pulmonary embolism severity index, which is a clinical score integrating PE severity and comorbidity, and is more extensively validated to date. And its principal strength lies in the reliable identification of patients at low risk for 30-day mortality. We also have what we call the simplified version, which actually gives a prognostic, which is a prognostic performance, which this prognostic performance is actually confirmed in cohort study. So this is actually the pulmonary embolism severity index and the simplified one. Okay, so here you're looking at these parameters: the age, the male sex, okay, the cancer. Of course, each of them gives you a different score. So if the patient has any of this, so this scores actually will be assigned to it. Okay, so using the PES scoring. So if in terms of for risk stratification, if it's less than 65, then that can be regarded as class 1, and that has a very low 30-day mortality risk. Then if it's between 66 to 85, it's actually a class 2. And also with a low 30-day mortality risk. Okay, now if it's more than 125, then it's actually a class 4 with a very high 30-day mortality risk. Okay, then the 5 pulmonary embolism severity index is called as shown below, with its relation to 30-day mortality risk. Now, the risk assessment of acute PE begins upon suspicion. So, for what patient comes, of course, we want to present what patient presents with maybe dyspnea and all that. So, we want to assess this patient, okay, and also the pair. It also begins with initiation of a diagnostic workup. So at this early stage, it's critical to identify patients with a high risk pulmonary embolisms. Now, in the absence of hemodynamic stability at presentation, so further risk stratification of PE is recommended. This has implications for any discharge and hospitalization or for monitoring of this patient. Now, this actually shows, you can actually use this in terms of classification of this patient, pulmonary embolism severity. Okay, then you have what we call the high, then the intermediate, where you have intermediate, high, intermediate, low, and then the low risk. Then for low risk, of course, what actually the indicators are used here at the hemodynamic stability. You have the clinical parameters of pulmonary embolism severity, or the way you have the pulmonary embolism severity index, okay, and then you have the right ventricular dysfunction either on the transthoracic echo or on CTPA. Then also use the elevated cardiac troponins in this classification. Then, if in terms of high risk, then of course we expect the patient to present in have a hemodynamic stability, and then of course the severity index also will be present. Okay, almost between class 3 to 4. And then when you do your echo, then there'll be presence of right ventricular dysfunction. Then also cardiac troponins will be maybe elevated here. Then for intermediate, which is classified into intermediate high and intermediate low. For intermediate high, there is no hemodynamic instability. Okay, and then this patient they have clinical parameters of the PE severity, and on your echo, there will be also a right ventricular dysfunction and also a troponin elevated. So this is different for intermediate low, where you have just the clinical parameters that will indicate PE severity. Okay, and then with one or none of either the right ventricular dysfunction or elevated cardiac troponin. Then low is only depending on is where none of this is present, and the assessment is optional if assessed. Okay, then it may be negative in terms of the troponin. This is just what I said earlier. So the in addition to clinical parameters, especially intermediate risk group who display evidence of both right ventricular dysfunction and biomarkers level circulation are classified intermediate high risk. So this is just what the table actually shows. Now, for this is actually a diagnostic algorithm for patients with suspected high-risk pulmonary embolisms. So where if a patient present and suspected PE with hemodynamic instability, it can actually bedside echo is maybe very helpful here. Because at this point, patient might not be able to get to the probably there be some because of instability, patient might not be transported for other image like a CTP. So bedside transthoracic echo is useful here, where if there is a right ventricular dysfunction, you want to probably go ahead to do a CTPA if it's available and feasible. Then if you do a CTPA and there is and it's positive for PE, then you want to treat patients as such. Then if it's negative, you have to search for other causes of shock or that's causing the instability in this patient. Then if it's also if you do a right ventricular dysfunction and it's not present, check with your echo and there's no right ventricular dysfunction, then you have to search for other causes of shock in this patient. Then this is for patient without hemodynamic instability. So at this point, you're not really in a hurry, but however, you want to base your judgment using the clinical probability, okay, to find out whether this patient is at low or intermediate risk or high clinical probability. So if the patient is low or is under intermediate clinical probability or PE unlikely, then you want to go ahead to do your dimer test. Then if it's negative, then there's no treatment. If it's positive, you have to go ahead to do your CTPA. And if it's positive, then you treat the patient as such. Then if there is no PE, then no treatment. Then if under the high clinical probability, you want to go straight to do your CTPA. So which may confirm PE, then to warrant immediate treatment. Then if there is no treatment, if there is no PE, then you have to investigate further to ascertain other possible cause of patient symptoms. Now, this actually shows a class of indication for some of those assessment of this patient. For as a class 1 indicator, the initial risk stratification of suspected or confirmed PE based on the presence of hemodynamic instability is recommended to identify patients at high risk of early mortality. It's also a class 1 that is recommended that in patients without hemodynamic stability, further stratification of patients with acute PE into intermediate and low risk categories is recommended. Okay. Now, as a class 2 indicator, the patient without hemodynamic stability, use of clinical prediction rules, integrating PE severity and comorbidity. Okay, preferably the PESE, that's the pulmonary embolism severity index, or the simplified form, should be considered for risk assessment in the acute phase of PE. It's also a class 2 indication to assess the right ventricular function by imaging method or laboratory biomarkers. Okay, so this should be considered, and even in the presence of low pulmonary embolism severity index or a negative simplified form. Okay. Now, look at the management of pulmonary embolism. You want to actually approach the patient looking at the acute phase. Now, whereby patient may actually need a hemodynamic and respiratory support. So in this case, you want to carry out your oxygen therapy and ventilation. So supplemental oxygen is actually injected if the oxygen saturation is less than 90. Okay. Now, severe hypoxemia or respiratory failure, refractory to oxygen supplementation, they want to suspect a right to left shunt, either through PFO or presence of intraseptal defect. Okay, because actually be giving patients the patient remains hypoxic. So we want to assess or consider some of these factors. Now, other techniques which can be applied in extreme instability is a high flow oxygen and mechanical ventilation. Okay, and then important to know that correction of hypoxemia will not be possible without. Okay, now if intubation is needed, we want to avoid anesthetic drugs that are more prone to cause hypotension. In fact, it is said that if it can be avoided, because intubation can actually worsen the patient's condition, it actually cause hypotension and all that. So if you can avoid it, so once you can actually go to your high flow oxygen and all that without intubating the patient. Okay. Now the pharmacological treatment of acute aortic failure is also is the next thing that we want to do by looking at the CVP modified by CVP modified, because you don't want to overload this patient. Okay, of course, aggressive volume expansion is of no benefit, and this may worsen the right ventricular function. So, but you want to use the vasopressors or in this case. Now, norepinephrine improves systemic hemodynamics by improving the ventricular systolic preparation and coronary perfusion without causing change in the coronary vascular resistance. So its use is limited to patient with cardiac shock. Now, you want to also consider the use of mechanical circulatory support, like the ECMO and Impella, okay, for short-term support. You know, so this may actually be helpful in patients with high risk PE and who may have the circulatory collapse or cardiac arrest. Now, initiation of anticoagulation is very important. Okay, so it can actually be parenteral anticoagulation in the use of also use the low molecular weight heparin and fondaparinux, which are preferred over unfortunate heparin, because the unfortunate heparin actually carry a lower risk because this lower molecular weight heparin they carry a lower risk of major bleeding, which can be seen in unfortunate heparin. Also, the unfortunate heparin also cause the heparin to thrombocytopenia. Okay, now the use of unfortunate heparin is restricted to patients with overt hemodynamic stability in whom primary perfusion treatment is necessary because of its short acting. So you want to use that in case you want to carry on some interventions. Now, it can also be useful in serious renal impairment or severe obesity. Okay, so other anticoagulants that can be used are the NOx. Okay, and then vitamin K and warfarin. Now, there's actually a phase 3 trial in the treatment of acute PLVT, as well as those on extended treatment beyond the first 6 months. It was noted that there's a non-inferiority of NOx compared with the combination of low molecular weight heparin and vitamin K for the prevention of symptomatic or later VT occurrence. Okay. Now, allowing significantly reduced rate of major bleeding. Now, when vitamin K antagonists are used in combination with either low heparin should be continued in parallel with the oral anticoagulant, okay, for at least 5 days until the INR is between 3 to 2 to 3. Now, for revision treatment, this involves the systemic thrombolysis with the greatest benefits if given within 48 hours of patient symptoms. And that, however, it can also be used for up to 6 to 14 days of patient's condition. Now, now you want to look at also successful thrombolysis. Okay. This may be as a result of persistent clinical instability or when there is unchanged vascular dysfunction of echo after 36 hours. So it may actually be unsuccessful if these are the case. Now this is actually trial is looks at the set to actually determine the whether normotensive patients which are under intermediate risk will benefit with confirmed pulmonary embolism. Okay, terminal patients with confirmed pulmonary embolism and right ventricular dysfunction. Okay, that was to find out whether the use of thrombolytic treatment may benefit them. Okay, so it was actually shown that there's actually some benefit in this case. So it can be used in this group of patients. Okay, but however, it carries some complications like bleeding, which was intracranial or extracranial bleeding, or even ischemic stroke within 7 days. Okay, so now these are just the regimens, the doses, and the so we have the smooth activator, the streptokinase and the leukinase. So these are the common ones that are used. Okay, and there are contraindications to their use. Now, the percutaneous directed treatment is also another method. Direct type of the different type of catheters. It can actually be useful for mechanical fermentations or thrombus aspirations, and also use a pharmacomechanical approach whereby you combine mechanical or ultrasound fermentation of thrombus with in situ reduce those thrombolysis. Now, also do a surgical embolectomy. Okay, now you want to look at the compare surgical embolectomy with the thrombolysis. It has been shown that there is no difference in terms of mortality, either 30 or 5, either 30-day or 5-year mortality. Okay, when compared with thrombolysis. Okay, but however, thrombolysis group actually has a higher current admissions and even stroke and reinterventions. Now, this actually shows the use of some of these agents. Now, it is recommended that anticoagulation with unfortunate heparin, including weight adjusted bolus injection, be initiated without delay in patient with high risk PE. Then systemic thrombolytic therapy is recommended for high risk pulmonary embolism. Is also a class 1 indicator. Then surgical pulmonary embolectomy is recommended for patients with high risk pulmonary embolism in whom thrombolysis is contraindicated or has failed. Now, the use of ECMO is a class 2B, okay, which may be considered in combination with surgical embolectomy or catheter-directed treatment in patients with pulmonary embolism and refractory circulatory collapse, or in case of cardiac arrest. This also just to another recommendations where initiation of anticoagulation is recommended without delay in patients with high or intermediate clinical probability of PE, while diagnostic workup is in progress. So it's important that once you suspect a PE and all that, in terms of high or intermediate clinical ability, then they want to initiate your anticoagulations while you work on patients. Then it's actually a class 1 indication. Then if anticoagulation is initiated parenterally, then don't recommend heparin or fluoroquinolones is recommended over unfortunate heparin for most patients. Now, for reperfusion treatment, is a class 1 indication to that rescue thrombolytic therapy is recommended for patients with hemolytic deterioration on anticoagulation treatment. And routine use of primary systemic thrombolysis is not recommended, so it may be helpful, okay, if used in patient with intermediate or low risk PE. The another thing that can also be used is IVC filters. Is a class 2A that the use should be considered in patient with acute PE and absolute contraindications, to anticoagulations. And it should be also considered in patient with PE recurrence, despite therapeutic anticoagulations. Now, this is actually is looking at the risk-adjusted management strategy for acute pulmonary embolism. Okay, so where you want to, like, once a patient is active PE, then you have to coagulate. Then if there is the hemodynamic instability, so this actually will help you to know which patient you want to admit or what you want to actually send home. Now, if you want to assess this patient, if there is any hemodynamic instability, if there is a hemodynamic instability, then that is a high risk. Then you want to commence your reperfusion treatment, okay, and then hemodynamic support. Then, if there is none, then you want to actually distinguish low from intermediate risk. Okay. Now, you have to do this using the clinical signs of PE severity or serious comorbidity. Okay, this is where you apply your pulmonary embolism severity index. If the class is between 3 to 4, okay, then you may want to perform troponin test. Okay, so if it's positive, with presence of right ventricular dysfunction, you can classify that patient as intermediate high risk. Now, if the troponin test is negative, then that's intermediate low risk. Then for low risk, in this case, there is no other reason for hospitalization. Okay, after you've carried out your clinical signs of PE severity, and also you've done your airway dysfunction on the echo. Okay, so when neither of this is present, then that is low risk. So you want to actually determine whether you want to hospitalize this patient or no. Then, if no other reason for hospitalization is present, like the patient has a family or social support, okay, then you will want to discharge the patient, okay, and do a home treatment. Then, if the patient does not have support and doesn't have an easy access to medical care, then it may be the patient's interest to be admitted. Okay, now one of the criteria things that actually used to assess this is also what we call the hairstyle criteria. This is actually just what you can actually do by the bedside. Once either of these, if one of the questions is answered yes, then the patient cannot be treated at home. So we want to use this to quickly assess to know whether this patient be discharged or not. So if we all know, then the patient actually can be managed from home. Then for early discharge, it's considered that these patients should be carefully selected. The carefully selected patient with low risk PE should be considered for early discharge and continue continuation of treatment at home if proper outpatient care and anticoagulation treatment can be provided, like I said earlier. Okay, now the chronic treatment and prevention of recurrence. Now, there are actually few landmark clinical trials that actually shown had some stated something on the duration of anticoagulations. Now, first is that all patients with PE should receive at least 3 months of anticoagulant treatment. And that after withdrawal anticoagulant treatment, the risk of recurrence is expected to be similar if anticoagulants are stopped after 3 to 6 months compared with longer treatment periods. Now, thirdly, the conclusion, one of the conclusions is that extended oral anticoagulant treatment reduces the risk for recurrent VTE by less than 90%. But this benefit is partially offset by the risk of bleeding. So this actually just shows the different estimated risk for long-term recurrence. So we want to use this to assess patients that are more likely to have a recurrence. So you can put them under low, intermediate, and high risk. Now, for low risk, then there's the major transient or reversible factors, which there's more than tenfold increased risk for the index event when compared with patients without the risk factors. Then we also have the high risk, where in cases of where patient may have patients that have active cancer, or have one or more serious previous episode of the VTE in the absence of a major transient or reversible factors, or even if the antiphospholipid syndrome. So these are patients that may require a long-term or even a last-term anticoagulant. Now, based on current available evidence, the risk factors that are associated with bleeding risk are listed. Have advanced age and previous bleeding, active cancer, previous stroke, or even a patient with renal insufficiency, and whereby we also that concomitant use of antiplatelet therapy or NSAID, okay, and then other serious acute or even when there is poor anticoagulation control, where by probably using the iron now, there is a poor monitoring. The patient may actually be at risk for now, for patient without cancer, the therapeutic anticoagulation for more than 3 months is recommended for patient. Okay. Now, for patient in whom discontinuation of anticoagulation after 3 months is recommended, then you want to for patient with first BE or VTE, secondary to a major transient or reversible risk factors. Now, the discontinuation of therapeutic oral anticoagulation is recommended after 3 months. Okay. Now, it's also a class 1 indication to that oral anticoagulant treatment of indefinite duration is recommended for patients presenting with recurrent VTE. That is with at least one previous episode of PE or DVT that is not related to a major transient or reversible risk factors. Okay. But now for patients with active cancer, now for patients who have pulmonary embolism and cancer, now the weight adjusted subcutaneous low molecular weight heparin should be considered for 6 months over the use of vitamin K. This is actually on the class 2A. Now, looking at the pulmonary embolism and pregnancy, now active PE remains one of the leading causes of maternal death in high-income countries. Okay, and this risk is higher in pregnant women when compared with non-pregnant women of similar age, and increases during pregnancy and reaches its peak during the postpartum period. So the baseline pregnancy-related risk increases further in the presence of additional VT risk factors, okay, including picture violation or obesity, and some of those risk factors. So when a patient is pregnant, that's pregnant, they also have this additional risk factors. So that's actually increasing the risk for PE. Now this is just an algorithm assessment of patients with suspected PE during pregnancy. So by the use of high pretest probability or intermediate or low probability, then or with a positive D diamonds, they want to initiate the anticoagulant, with a low molecular weight heparin. Okay, then you can go ahead to evaluate the patient using this investigation. This chest X-ray actually say that it has some of these recent imaging modality and equipment. They may have a low risk in terms of the radiation dose, for that may not be enough to cause any fetal mortality. Okay, so but however, I actually use compression of proximal Doppler's ultrasound. Okay, if symptoms or signs are suggestive of DVT. Now, if proximal DVT is present, they want to continue with low molecular weight for this patient. Okay, and then you assess the PE severity and the risk of early death. Okay, then early referral is also very important. Then, if proximal DVT is not present, then you may want to carry out further investigations. Okay, to either rule out or classify this patient into intermediate, whereby you want to further review this result of this image with a radiologist, okay, for proper diagnosis. Then, if it's positive, then you also want to go ahead to treat this patient. Now, the is also the formal diagnostic assessment with validated method is recommended if PE is suspected during pregnancy or in postpartum period. It's actually a class 1. Now, the therapeutic phase dose of low-weight heparin based on early pregnancy body weight is the recommended therapy, okay, for instability. Now, what are the possible? These are actually the possible sequel of pulmonary embolism. We have the recurrent PE, recurrent premature embolism. Okay, but these patients are at risk of that. And then you have what we call post-pulmonary embolism syndrome, where the patient will have persisting symptoms and functional limitations after PE. Okay, and also another complications that also may occur is the chronic the chronic thromboembolic pulmonary hypertension. Okay, which is actually a rare and debilitating disease. Okay, that are characterized by patient with persistent with pulmonary hypertension, or they also have a chronic thromboembolic blood clots in the lungs. Okay, so now in terms of follow-up, this algorithm just shows how to follow up these patients. Okay, now for a patient that's on anticoagulation, we want to follow up for at least 3 to 6 months. Okay, and each of this period we want to assess for the breathlessness or the functional capacity of this patient. Okay, then if there is presence of the dyspnea, the functional limitation, then we want to further evaluate this patient using thoracic echo, to determine the probability of PE. If it's low, then you seek alternative symptoms, what may be causing these symptoms. Then if it's intermediate, okay, then you want to consider further investigation and the NT-proBNP. You want to assess for risk factors for CTP, for CTEP, and also you want to also check if there's a normal CPET result. Now, if you also do your echo and it's falling under high, then you want to go ahead to do a VQ scan. Then if there is mismatch, perfusion defect, then it's important to refer this patient for pulmonary hypertension. Okay, management. Now, if there is if none of these symptoms exist, then it's also important to assess this patient for risk factors, because most time it may actually be symptomatic. Okay, asymptomatic. Then, if it's none, then you want to focus on anticoagulation and secondary prophylaxis, and then to advise to return if symptoms appear. Now, routine clinical evaluation of a patient 3 to 6 months after the acute PE episode is actually recommended. Okay, and just a class 1 indicator that integrated model of patient care after PE, okay, involving hospital specialists, appropriate qualified nurses, okay, and is recommended to ensure optimal transition from hospital to community. Another class 1 indication is that in symptomatic patient with mismatched perfusion defect, persisting on a VKIC scan beyond 3 months after active PE, referral to a pulmonary hypertension or CTF expert center is recommended after taking into account the result of echocardiography, the peptides and also. Okay, then class 2A, further diagnosis evaluation should be considered in patient with persistent or new onset listening or side limitation after PE. Okay, thank you so much. These are some of my references.
Thank you so much, Dr. Ibe, for this extensive presentation. So we'll open the floor for comments and questions.
Hello.
Yes, please.
Okay.
Any question from participants for Dr. Ibe? I guess you've done a good job. So the comments on the chat box are all saying thank you for a great presentation. So as to save time, I'll hand the floor over to our chiefs. Chief Adeanju, if you have any comments to make.
Good evening, everyone. Thank you, Dr. Conte. Dr. Cassidy, thank you very much. I think it has been a very good presentation, and we was able to go through every necessary thing that we need in case if this one comes out in the exams. I think that the area of focus, we should know the echo findings in PE, and we should know all those scoring systems. They are very important. Also, the thrombolytic agent, I think, is something that we should know in case if, I think those are that I was able to note. Thank you.
Thank you.
Is Dr. Orimolade on the call?
Yes, thank you, Dr. Conte. A very big
Yes.
thank you to Dr. Ibe for this presentation. It was quite extensive, and I must say he has really put in a lot to make this possible. You touched on so many aspects. PE in pregnancy is an aspect to note too for exams, and alongside with what Dr. Adeyanju has mentioned. So, and I'm so glad that you touched actually that aspect. Then the timing for thrombolytic therapy should also be noted, and other surgical management like suctioning or what they call that thing, thrombectomy that can be done should also be noted. Then, our own time we saw clot in the left ventricle as part of they brought an echo. So like Dr. Adeyanju mentioned, it's possible they can bring an echo picture of things that could depict pulmonary, you understand, things we see in pulmonary embolism. It's going to be a moving image, like it was suggested during our own last exam. So the Marconi sign is important to note, as well as what they call it, CT findings in pulmonary embolism. That's the chest CT now, or angio as the case may be. Could be an OSCE question, because we saw MRI and chest CT2 came out in our exam. So we could expect that for exams. So high yield area, that meaning investigation for pulmonary embolism. Then I've mentioned PE in pregnancy. Yes, thank you. Thank you so much for the presentation.
Thank you. Thank you.
Okay, thank you once again, Dr. Ibe. I think you can unshare your slide. I'll hand over to Florence. I think we can still take a few more MCQs before we close the session for today. Thank you.
Okay, thank you so much, Dr. Cassidy. You really did a wonderful job there. And also thank you for everyone who contributed, and also to our chiefs who also contributed. Okay, so we would want to move over to the MCQs. We are begging that we would extend it by 30 minutes, as we'll round up by 10:30, 11:30 rather. So please, we just need your patience. Thank you. Okay, the next person is Dr. Ayodeji. Dr. Ayodeji here?
Yeah,
Dr.
I'm here.
Ayodeji?